The next part of our program, we've invited 4 additional stakeholders, frontline healthcare workers, a family member advocate, to talk about their personal experiences with infection prevention and control in healthcare settings. Our first speaker is MJ Burke from the VA Council. MJ?
Hey, thanks for having me. So let's talk about what problems we encountered. I work at the VA, and we are the largest healthcare system in America. Traditionally, we really had a safety program that was robust, but being the largest healthcare system, we even faced a lot of challenges during COVID. So I'm going to go through like 3 problems, and they were all covered. I seem like a genius, when we have all these PhDs talking about this stuff. But I think from a frontline perspective, when things don't seem right, you heard like Kim about it, who is the ICU nurse. It gives me reassurance that we have like these scientists behind us that are echoing things that I know even like by infection control doesn't make sense to me. So problem 1, and this is really, I wrote this before I heard all these. I have not seen CDC studies for COVID that replicate real life occupational task demands. And what I mean by that, even my coworkers, as a physical therapist, if you're dealing with infectious disease, especially respiratory, I want to kind of talk you through. You have to go down like someone's supine, you grab their inferior angle of their shoulder. So you're like this close to their face with a surgical mask, and you're hoisting them up, and then you're just holding them because they're so weak. So 2 things, the vicinity is a lot closer than people would think. And then 2, you're moving those secretions up, and you know what's going to happen. And I have a surgical mask on, especially early in the pandemic. And the conversations we had with nurses, especially about activities that were not respirator worthy, things that kind of don't make sense to me, like, you find 50% RNA COVID positivity and diarrhea. We use these air mobility mattresses, and yet that activity wasn't respirator worthy. Just like dementia patients at CLC units, you're having to help them do exhale, through that. And a lot of those at the time weren't respirator worthy. So when there was a question about lists, the things that were airborne was like they said aerosol procedures, which are typically EGDs, nasal swabs, respirator nebulizing treatment, and that was it. I mean, we could not get a respirator if it wasn't kind of on that list. And so I think before you rule out stuff for aerosolization, I think you have to have those studies. Otherwise, you should plus up the isolation procedure. 2, you heard people talk about reuse and contingency options during the pandemic. I called it the brown paper bag syndrome, where they were being asked to reuse respirators. And I didn't even know what an elastomeric, I had seen elastomerics before, but I didn't know they were readily available until like way after. And when I found out, like small facilities in Texas for TB had always used elastomerics, the fact that we were doing brown paper bags should have never, ever been on the CDC website. And that really kind of angers me. And when a facility is not required to give public notice when they go into contingency operations, whether that's for staff and they don't have enough staff to cover isolations, or they have to double cohort rooms for isolation, or they don't have respirators, it makes like the CDC guidance kind of a mockery when it's like kind of optional if available kind of thing, because at the very least you should be having to give public notice if you're going below some of these things that are really more evidence-based. And number 3, this wasn't talked about, but I think it should be talked about a little bit more, is training and CDC communications regarding isolation transmission recommendations. I mean, some of the things is like the posting of contact plus, droplet plus, and even, airborne plus all these signs look different. I don't think there's a requirement necessarily to put like what that graphic image of what it should look like when you go in the room. They all are different. Every facility kind of looks different. And so as a consequence, you get like variation of like, well, what is this? And a lot of training is done on a computer rather than in reality. And so the recommendation there is like, I think we should be doffing, especially PPE on a quarterly basis, making sure that we're doing the right procedure. There can be a lot of cross-contamination there. To give reference, like we do CPR on a quarterly basis, and we're doing like the most deadly thing, and it's kind of like, yeah, do a computer-based model. So I think there are some very helpful, very practical things that we can do to make things better. And actually mine were the same for Lisa. Recommendations, elastomeric for a big system like that should be in your emergency response caches. Notice to public workers when you're not in conventional status, whether that's room, respirator availability, or shared room cohorts due to staffing, and coworkers looking at you, doffing especially PPE in the full garb. Done on a quarterly basis, because we will always have some sort of novel respiratory, and that's it.
Thank you very much, MJ. And we appreciate your comments very much. As a reminder, please put your recommendations for the CDC in the link that we've provided, and Jane just put it back in the chat box. Next, we have Rita Lewis, who's a nurse with experience in correctional facilities. Rita?
Hi, and thanks so much for having me. Okay, I'm a retired registered nurse, and I worked for 15 years with California Correctional Healthcare Services at San Quentin State Prison. So I'm speaking for the incarcerated population and those of us who serve them. The point I would really like to make is that it can never be assumed that the Department of Corrections will practice common sense or prioritize the safety of inmates, employees, or the community. They have books of considered policies and procedures, but just like in the movies, prisons are their own bizarre, dysfunctional fiefdoms under the control of wardens and department managers' whims. Cal Human Resources issued a really detailed memo about COVID and risks and recommendations. And then the governor issued his executive stay-at-home order in March of 2020. Many state offices packed up their desks and became teleworkers. Essential departments were the exception. And for corrections, this provided justification for maintaining the status quo. In April of 2020, in my role as a union steward, I reached out to the leadership. I was perplexed by the fact that while the world was on lockdown, there were really no efforts to curtail staff or inmate movements at San Quentin. That they did grant some inmates early release, but with staff, it was business as usual. I couldn't understand why the movement of staff, vectors, in and out of the prison, a contained environment, wasn't being curtailed. Of note, when it's foggy, they institute fog line and minimize movement for safety reasons, but nothing was really happening. There were no modified schedules. They didn't put us on weekend holiday schedules or like a graveyard shift type schedule that minimizes employees, or alternative schedules, 12-hour shifts to reduce the traffic coming and going, or staff rotations. There was no serious review of telework for desk-based and support staff so that those essential services could be provided remotely from a safe distance. I reached out to local Marin County Public Health to share my concerns. They did make recommendations, but I learned that they have no jurisdiction over the state facilities, and their recommendations and feedback were mostly ignored by San Quentin Healthcare. So there was this missed opportunity for the ounce of prevention. And so that didn't happen, but the pounds of cure did happen as all hell broke loose when a large group of inmates, many COVID positive, transferred from another prison to San Quentin without proper testing or isolation. Coronavirus rapidly spread, resulting in thousands of staff and inmate infections, dozens of hospitalizations and intubations, and 28 deaths. This is at one prison. Statewide, there were tens of thousands of infections and hundreds of deaths. There were contracted medical staff flown in at great expense to manage the sick and recovering patients. The workplace safety violations that led to this crisis eventually resulted in a $421,000 fine, Cal OSHA's largest single penalty. But it's important to note that healthcare leadership at San Quentin includes a CEO of healthcare, chief medical executive, chief physician and surgeon, chief nurse executive, chief support officer, and at the state level, there's a federal receiver, deputy directors, regional directors, public health and infection control directors, and nobody from that list of leaders intervened at any step prior to this crisis. And ultimately, nobody was held accountable or took responsibility despite hearings and fines. Of note, the fine, there were other fines besides the $400,000 fine, but that's paid for by taxpayers. So there were really no consequences to the powers that be and the people in charge. So here we are, fall of 2023, RSV, norovirus, influenza, COVID is alive and well. And were any lessons learned? Are they actively doing anything to prevent this type of thing happening again? Are there universal masking in clinics? No, there is PPE access and they do fit testing, but there's no real ongoing education and postering, as MJ mentioned, installation of UV lighting, improved ventilation, no indications of, and this is a very old facility. And even in the new building, the health services building where I worked, my office had a window that didn't open and shared ventilation with the whole building, including 50 inpatient beds. So that has never really been looked at with any real scrutiny. And again, no real plans to control the flow of people. I think it's really important to think of telework and staffing issues as safety. You know, people think of telework, oh, it's so convenient, but it's a huge safety advantage to minimize to and from. So in conclusion, and there were actually hearings, the Little Hoover Commission, which is a instructive commission for the state of California, had hearings in 2020 on transitioning state government workforce to permanent remote work. Recommendations largely ignored, still ignored. So the bottom line is with corrections, they're always reactive and never proactive. And follow through is based on the subjective discretion, the whims of each department, ultimately enabling the management to abandon common sense, evidence-based practice, and any concern for the always vulnerable inmates and high-risk inmates, employees, and with no regard for community safety and not insignificantly taxpayer dollars. So thanks for letting me speak.
Thank you very much, Rita. Our next presentation is Fiona Garza Tulip, who's a patient advocate.
Hi, everyone. Good afternoon. My name is Fiona, and today I want to share with you the story of my mom, Isabel Odette Hilton Papademetrio. She was a 64-year-old respiratory therapist in Dallas, Texas, who lost her life to COVID-19 on July 4th, 2020. See if I can see myself. Okay. My mom was in the business of helping people breathe, yet ironically, it was her breath that was taken away, all due to lack of proper infection control measures at her workplace. Despite working in a rehab unit, HIPAA laws prevented her from knowing if her patients were COVID positive. She probably performed breathing techniques with patients who were COVID positive, all without knowing. And also to add to that, her hospital didn't offer training or adequate PPE. In fact, the PPE that she was using were expired surgical masks, very much like the ones that, I buy off of Amazon in bulk. And she had to turn them in at the end of each shift. So her hospital didn't offer adequate training, didn't have the N91 masks. And when she started feeling COVID symptoms, they couldn't give her a COVID test. They asked her to find it somewhere else. They took her temperature, said to drink lots of fluids. So she spent 2 excruciating days while already fatigued from the virus to find a testing center. We all thought it was a mild case until it was too late. My mom was a meticulous person. She documented her symptoms, her fever, her food intake, all in a notebook. But what she couldn't document was her fear and her struggle and the profound impact her loss would have on her family. We thought she'd pull through, and she even texted me to assure me that she'd be there for her only grandchild, my daughter, Lua. But in the span of 1 week, we lost her. And unfortunately, some of her colleagues were at the hospital, former colleagues were at the hospital trying to save her, but she died pretty quickly. You might wonder why I'm sharing the story, and it's because we need a change, a systemic change in how healthcare facilities manage infection control. Lives are at stake. My mom's life was at stake, and she was let down. She trusted the very hospital that didn't protect her. My mom was a very energetic person, full of life, full of love, especially for my daughter. And even after her passing, we received a pair of pink frilly sandals she had ordered for Lua. That was my mom. She was always thinking of others, even in her last days. So I urge everyone, let's not make the same mistake twice. Let's prioritize education, training, and resources for healthcare workers who are the backbone of our healthcare system. And let's ensure that no other family has to go through what mine did. Thank you for listening.
Thank you, Fiona, for sharing your story. And finally is Matt Calzia, a registered nurse with the Oregon Nurses Association.
Thank you. That was a tough story to hear. I appreciate you sharing that, Fiona. My name is Matt Calzia, and I'm the Director of Nursing Practice and Professional Development at the Oregon Nurses Association. We represent about 15,000 registered nurses. And I've been a nurse in Oregon for 12 years, and I do continue to provide direct patient care at a local hospital. During the peak of the pandemic, I sat on an Oregon OSHA Rules Advisory Committee as we established an emergency COVID-19 temporary standard. And my experience working with and listening to the hospital lobbyists and those who wanted to minimize regulations was simply that hospitals want the least amount of regulations possible. And it does not necessarily need to be evidence-based. And they want to be able to operate by meeting the most minimum standards possible at the expense of their healthcare workers. Frontline healthcare workers were wronged by their government agencies and their employers during this pandemic, and they continue to be wronged. We were frequently told there was no aerosol transmission in the beginning, and we on the front lines were concerned that that was not true, and we felt that we needed an abundance of caution and precaution while the science catches up. When it was acknowledged that aerosol transmission occurs, there was inadequate PPE available to protect healthcare workers, and we began engaging in the risky practices of reuse and reprocessing of PPE. And then when we went out and we found our own elastomeric masks, we were told by our employers that we would face discipline if we were to bring those into our care environments. And many of these in emergency departments and other areas where we know that there was a lot of transmission occurring. In recent months in Oregon, we have seen entire operating room departments shut down because of staph infections of COVID as hospitals try to find the least amount that they can do to protect their staff members. And when these outbreaks occur in hospitals and other care environments, we exacerbate a backlog of care that is needed to be delivered to our communities. And it just continues the problems that we see of people's chronic illnesses being compounded and more complicated because of delays in care. Nurses and frontline healthcare workers need the CDC's Healthcare Infection Control Advisory Committee to operate in transparency and to include the voices of frontline healthcare workers over the desires of healthcare executives. The reality is this pandemic eroded trust in that agency, in the CDC, because it was of inadequate and inconsistent response. And the only way to reestablish that trust is to do it with evidence-based guidelines that provide an abundance of protection for workers, not loopholes for employers. I appreciate everybody's time and comments today and for allowing me to participate.